Can I, before they're sworn, once again welcome a panel of distinguished experts, two of whom you've already met during this week, those of you who were here yesterday, and welcome back. But welcome to the other four. I know that you're all busy practitioners, and so we are especially pleased that you have made time in busy timetables with other responsibilities to be here to help us. Thank you. May they be sworn.
Please state your full name.
Trevor Gareth Tudor-Williams.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and confirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Graham Stephen Cooke.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Sian Edwards.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
Truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
David John Johnston.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Ian Jeffrey Williams.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Please state your full name.
Jane Anderson.
And repeat after me. I do solemnly, sincerely.
I do solemnly, sincerely.
And truly declare and affirm.
And truly declare and affirm.
That the evidence I shall give.
That the evidence I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Ms. Scott.
I'm going to start by asking you to introduce yourselves and say a bit about the experience and expertise that you bring to the inquiry. But can I start, first of all, with you, Professor Tudor-Williams, with an apology that you have been demoted on your name tag up there to doctor, but to reassure you that your correct title has been put in the report. And so can I start with you?
Well, let me say I am a doctor, and I'm a paediatrician, and I first looked after a child that we diagnosed with HIV at St Mary's Hospital along the road in Paddington in 1988. And since that time, I have been working with children and young people infected and affected by HIV. I spent 5 years in America specializing from 1989 to 1994. And since then, I returned to join an extraordinarily accomplished group of colleagues running a family clinic for HIV-infected children and young people, and now adolescents and people in their 30s who are still from our surviving cohort. Thank you.
Professor Cooke.
So I'm Graham Cooke, and for those who weren't here yesterday, I've been working with patients living with HIV for over 25 years. I'm based at the same institution as Professor Tudor-Williams, and my focus really is on co-infection. I lead the co-infection services in that hospital, and the majority of my time now is spent on research, particularly around co-infection, but other aspects of HIV, including HIV diagnosis and cure work.
Ms Edwards.
Hello again. So my name's Sian Edwards. I started HIV work as clinical nurse specialist, bit of a misnomer at the time, which was in 1986 in Sydney. I came over and spent lots of the subsequent years in Zambia in Africa and in London and Australia, doing education and clinical work, teaching nurses and to care for patients with HIV and AIDS infection. I also spent 5 years as a clinical nurse specialist in the haemophilia unit in London at St Thomas's Hospital. And one of the reasons that I think I have been brought in by the inquiry is because I undertook 2 research projects with people with haemophilia and HIV, which many of you know of, looking at people's life histories and the experiences that they had been through, and then a second project with people who had were the relatives and the family members of those who had died of AIDS, who also had haemophilia. And I'm currently based in Melbourne in Australia.
Dr. Johnston?
Good morning. My name is David Johnston. I'm a general practitioner, and I've been a general practitioner for 25 years. During that time, I've been involved in a number of community initiatives and have also been involved in researching rural and isolated practice. So I believe I bring to the inquiry the perspective of a generalist, a non-specialist, if I can use that term. So thank you.
Dr. Williams?
My name's Ian Williams. I've been involved in the care of patients with HIV since 1987. I'm a consultant in gender medicine and HIV medicine and clinical academic, and have been directly involved in outpatient care and inpatient care, first at the Middlesex Hospital, then at University College London Hospitals, and I continue to do outpatient work. I've been chair of the British HIV Association, and my clinical academic role has largely been in treatment trials of antiretroviral therapy.
And Professor Anderson?
Thank you. Good morning. I trained at St Mary's Hospital. I'm a doctor. I specialise in HIV infection. I trained at St Mary's Hospital and first met somebody living with HIV in 1984 when I qualified. And I continued during my junior doctor years working in infectious diseases and was appointed as a consultant in HIV medicine at St Bartholomew's Hospital in 1990. I helped set up the first HIV unit at Barts and also worked at Homerton during that time. And in 2004, I moved across to Homerton Hospital, where I still practice in Hackney. I've been particularly interested in the care of women and families, and because of the population who use our clinics in East London, I've been particularly interested in black and ethnic minority communities and in migration. Other roles, I've also been chair of the British HIV Association, like Ian, and I currently chair our national campaign and policy charity, the National AIDS Trust.
Thank you. You've been provided with 2 letters of instruction from the inquiry and a summary of some of the evidence given to the inquiry, and you have provided a report to the inquiry, and you are due to answer some of the questions that were raised in the supplementary letter of instruction in a supplemental report. Is that right?
That's right.
And the report that you have provided, is that a report that all of you have read and all of you agree with the contents of?
Yes.
Yes.
And there are no areas of disagreement between you?
No.
Can I start then by asking questions about what HIV actually is? And I'm going to ask them generally, so anyone that wants to answer them, do feel free to answer.
Where should we start? So HIV is a virus, which is an infectious agent, and it belongs to a particular family, the retroviruses, and it particularly affects white T cells, the T lymphocytes, and its effects mean that when it infects somebody and gets into the cells, it disorders, the immune system becomes damaged and disordered. So essentially, it's an infectious agent that is particularly affecting the immune system of human beings. It comes in 2 main sorts, HIV-1 and HIV-2, which are quite significantly different, and the treatment of the 2 is different. HIV-1 has got a variety of subtypes within it, but we have some some major subtypes, which are the most common ones, and it appears that the natural history, what happens to somebody if with the different subtypes of HIV-1 is pretty similar across all of them.
And what are the differences in terms of what are the clinically significant differences between HIV-1 and 2?
Well, HIV-1 is responsible for the main pandemic across the globe. HIV-2 is largely limited to West Africa, but can be imported into other parts of the world. HIV-2 doesn't have the same natural history. It's much more. Doesn't have the same impact in terms of clinical consequence as HIV-1.
And I think the other thing I would add to that is the structure and the way the virus the structure of the virus means that some of the drugs that work for HIV-1 don't work properly for HIV-2 because the virus is of a different enough structure for the molecules not to sit in the right areas and work as well.
And is that the same the other way around? Some of the drugs that work for HIV-2 don't work for HIV-1?
It hasn't worked like that because, as Ian, I think, has alluded to, there are far fewer people living with HIV-2. And so at the moment, there are no specific drugs being designed for HIV-2. It's using the HIV-1 drugs in a way that is most appropriate for that virus.
And again, in terms of the different subtypes of HIV-1, are they clinically significantly different?
No, not really.
How does a person become infected with HIV? What are the infection routes?
Where should we start? So worldwide, the most common route of infection is through sexual transmission. And that can be from vaginal sex, from anal sex, from oral sex. So sexual transmission and sexual fluids are the most common route of transmission. It's also transmissible by blood and blood products. And it can also be vertically transmitted from a mother to an unborn child. And it's also transmissible by breast milk. And so the other modes of transmission, so for example, people who use intravenous drugs, that will be a microinfusion of blood. So that's blood-to-blood transmission usually. So sex, blood, vertical, and breast milk. Have I missed anything out?
No.
And what is the extent of viral exposure a person requires to become infected? You mentioned a very small amount. Could one particle of HIV infect somebody?
Well, I don't know whether, Graham, we were putting that in the some of that was going to be.
I think we will summarise some of this in the supplemental responses, but yes, that is broadly the case, and therefore the risk of being infected depends very much on a number of factors, including the quantity of virus that might be exposed, an individual be exposed to, and the proportion of that batch or product that may have been administered. And the risk of infection is then balanced by also the individual's susceptibility to be infected. So not all individuals are similar in their ability to be infected, and sometimes a similar exposure may or may not result in an infection itself.
I think Dr. Williams is going to add something.
I mean, just to give a sense of that, if you look at sexual transmission, then maybe 1 in 300 times when you might have will be this risk of sexual transmission, so about 0.03%, 0.3%. While if you have a transfusion of an infected blood product, then that's clearly, the likelihood of infection is uniform. But it's not, if you have a sexual exposure, then not everyone who has a sexual exposure will get infected.
So could it also be the case that if you had a number of people exposed to a batch of infected blood or blood product,
Yes.
not all of them would become exposed, not all of them would become infected?
Okay.
Yes, I think that is possible, yes. And I think without getting into too much of the small print, then, for example, there are a small proportion of individuals who carry particular genetic variation who may actually be refractory to infection. That's quite unusual. It varies across populations, but in a Caucasian population, maybe 1% of individuals may carry that mutation. If they have 2 copies, it might be very hard to be infected, and there is evidence that such individuals tend to be overrepresented in groups where there's been exposure without infection. But I don't want to suggest that's the most common reason. It's a relatively unusual issue.
I'd just like to add from a perspective of a paediatrician, the data suggests that drinking 1 litre of breast milk from an HIV-infected person who's not on antiretroviral treatment would be carry the same risk of transmission as one unprotected vaginal intercourse, so about 1 in 300 risk from 1 litre of breast milk, just to give you an idea that other body fluids are implicated.
And would repeated exposure to infected products increase the risk of a person being infected? So somebody that hadn't been infected on exposure 1, would that mean they wouldn't become infected at all on exposure up to exposure 10, or would that increase the risk?
So in general, yes, but I think with the caveats that actually there may be a small minority of individuals who are naturally resistant and actually won't get an increased risk of infection with more exposure. But in general, that increased risk of exposure is likely to increase the risk cumulatively over time in broad terms. And I think in our supplemental report, we'll go into a bit more detail about that for the inquiry.
Does anyone else want to add anything on that?
Just the other added exposure, of course, is the vertical transmission. So although somebody may be HIV positive, it does not mean that their baby will naturally be infected. And obviously treatment changes that a lot, but in the early days prior to treatment, we were talking 15%.
Yeah, no, the data would be if a person infected with HIV doesn't know their diagnosis, has a vaginal delivery and breastfeeds that child, about 1/3 of those babies would be infected. But it very much depends on the maternal viral load, and it could be as much as 2/3 if the mother has a very high viral load.
Is it possible to have HIV-1 and HIV-2 in one batch of infected blood product?
It's certainly not impossible. It would depend. Certainly, there are people who are living with both viruses,
There are.
and so it would be, I think, very unusual. But I wouldn't like to put a figure on it. But not impossible.
So the people living with both viruses, are there people living with different types of subtypes of the virus as well?
That's more complicated.
I think the subtypes are difficult because the virus evolves quite quickly in the body. It replicates very rapidly. It doesn't proofread itself, so it makes errors are introduced, and therefore you get a very broad sort of quasi-species, what's known as within the person who's infected. And so you may get a subtype B, but there could be known as recombinants, which are basically where viruses have come together. But it largely, you can generally determine whether someone's a subtype B or subtype A, generally from their DNA analysis.
I think it's worth saying that in the early days, I certainly remember back in the 90s, there was reports coming out of various corners of the world, including India, where they were claiming that there were all sorts of people infected with HIV-1 and 2, which was a complete misconception based on the fact that the test was picking up antibodies to either HIV-1 or HIV-2. It was reported as positive for HIV-1/2, and people were being... There were physicians who believed that meant that you got both viruses, and that simply was not true. In fact, I think in the UK, I certainly don't remember a single child that we've looked after over 25 years who had both viruses.
Certainly people can, I think Gareth's absolutely right, the testing and the technology and the laboratory differentiation of the different sorts of HIV-1 and 2 has become much more sophisticated. And those early tests often came back as a report which didn't necessarily differentiate. So I think that's a very fair comment. But in today's world, you can differentiate them. And we know that from certain parts of the world, there are people who are living definitely with both 1 and 2.
Just to add a couple of points, I think in our routine practice, it's very unusual to see patients with both HIV-1 and HIV-2. But I think, and so from a single donor, for example, that would be an unusual thing. Unusual. But where you've got products pooled, as we discussed yesterday, a little bit around hepatitis C genotypes, then it theoretically could be possible for more than one type of HIV to be present. And I suppose the other thing that might be helpful to talk about is superinfection. Yes. So it is possible, once you have an infection with HIV, to have a superinfection if you have a further exposure. And we see this particularly with sexual transmission even now. And then in that situation, you may have more than one type of the HIV-1 in circulation. It doesn't necessarily have big implications. We may come on to that, but it's definitely possible.
So superinfection relates to infection with a different type of HIV.
Where you can distinguish that virus from the one that the patient originally
before.
had. Yeah.
And presumably, does repeated exposure to the same batch of infected product then, would that increase your viral load? Does that change the nature of your infection?
So I think we tried to find evidence of this. I don't know if... So we found relatively little evidence to suggest that the viral load will change. But I think if people are aware of other evidence, that would be helpful.
No, I don't think the viral load will change. That very much depends on how the immune system of the individual who's infected responds to HIV and how well that protective immunity develops. And so the exposure to HIV and the inoculum with HIV in it, so the route of infection does not determine the natural history of HIV or the individual's response, right? It will determine the risk of acquiring HIV in terms of the size of the inoculum, which would be much greater with a blood product than it would be for sexual exposure. So the risks would definitely be different, but in terms of how the immune system then responds to that inoculum will be dependent on other factors, viral and host factors, which we can go into.
Perhaps we should go on now then to the stages of infection, of untreated HIV as you deal with it in your report. You identify three stages: early infection or acute or primary infection, chronic infection, and then advanced infection. So if we can just start with early infection. How is this characterised? What's happening when somebody's first infected in terms of the virus and in terms of their immune response?
When someone first acquires HIV, the immune system will respond like it will respond to any infection. It will recognise that infection and it will be activated. And it will try and produce an immune response to that. And generally that immune response can be detected after about 2 to 4 weeks following infection. So those responses can be divided into largely response by producing antibodies, which tends to protect or fight infection within cell-free virus, or produces responses that are cell-based, and that produces fights against infection within cells. And so that's the reason we use an antibody test to determine whether someone is infected, because that tends to become positive after 2 to 4 weeks and then evolves. After about 2 to 4 weeks, the viral load in someone, the amount of virus it replicates, it starts at the area where it was first inoculum and then spread throughout the body, and it will cause a replicate in high level, and the viral load in someone with primary infection is likely to be very high in the figure of millions, as opposed to someone with who's got a chronic infection, where it'll be in the thousands or tens of thousands. And then the immune system kicks in and tries to control the virus, as it would do with any infection. But because of the way how the virus affects the immune system fails to do an adequate job. It fails to clear the virus. But the quality and the strength of how someone responds to the virus is dependent on genetic factors. And so someone can clear the virus down to very low levels, and other people, they don't develop a very good immune response and have a very high viral load after 3 or 4 months. But during that first 2 to 4 weeks, someone can be unwell with symptoms of primary infection. And those symptoms are things like fever, headache, like a flu-like symptoms, often unrecognised or sometimes quite severe.
So in your report at page 21, you say this about the symptoms at that initial stage. The symptoms most frequently described are a raised temperature, a sore throat, mouth ulceration, enlarged lymph nodes, aching muscles and joints and tiredness. A short-lived pale pink rash is sometimes seen. Nausea, diarrhoea and weight loss can occur. Neurological symptoms are common and may include headache and aversion to light, photophobia. And so are those rarely fairly common side effects, symptoms at this stage?
Yes, they are. Because they are very much like flu-like symptoms, which people might, get with flu or similar viruses, they often go unrecognised. So, for example, in clinics, people presenting with primary infection is uncommon. People often get diagnosed much later, right? So we would, in terms of, it's far more common to get diagnosed with established infection than to present with primary infection, because those symptoms that we describe are very similar to many other flu-like symptoms or glandular fever or something like that, which people may not seek medical help with, and therefore the diagnosis goes undiagnosed.
And some people will report no symptoms, is that
Yes.
right?
Although interestingly, quite often when you do meet somebody who's newly diagnosed, asking if they have ever had a set of symptoms like this, more people than you might expect will say, actually, yes, it does jog a memory. So even if they haven't presented to clinical care, on closer questioning with a diagnosis, people may recall having had something.
And you go on in the report to say this: in rare cases, there may be signs of meningitis or of direct brain infection. In most people, the illnesses last up to 3 weeks and resolve on their own, and recovery is usually complete. So in those rare cases where there are more significant symptoms, do those symptoms also resolve on their own, or do those continue?
Well, no, severe primary seroconversion illness or primary infection can last several weeks, and it can result in hospital admission, particularly those with meningitis. So it can be a differential diagnosis of someone presenting with meningitis. And it's a part of how the immune system is responding to the infection. And some people, it can affect the immune system so severely that they develop an AIDS-defining illness during their primary infection, but that is really quite uncommon in terms of presentation to hospital. But yes, it can be quite severe and it can last several weeks in terms of symptoms, but it does resolve.
Can I just add that the only difference in children is that if you acquire HIV in the perinatal period, then unfortunately this is a neurotropic virus, and if it hits your brain as it's developing, that often had lifelong consequences. That wasn't so true for children meeting the virus for the first time during childhood, outside the perinatal period. But it's a very well recognised consequence in the natural history of HIV in perinatal transmission from mothers to children.
We heard yesterday about a window period when we were discussing hepatitis. Is that relevant to HIV, and if so, what is it, and why is it relevant?
It's relevant. As I said before, you develop symptoms of primary HIV infection when the viral load in someone is quite high, but the immune system is yet to develop sufficient antibodies to be detected by the assays that we use to diagnose HIV. So there used to be a period where from the last possible exposure to HIV to then having a test used to be a window period of 3 months, in terms of if someone had an potential exposure to HIV in that period of time, we would say we would want to wait until at least 3 months after that exposure to get a test. With the more modern assays that are now employed, the 4th and 5th generation assays, that is not so much the case. We can now identify someone with primary HIV infection, 2 to 4 weeks after exposure, because of the more sensitive assays that we use to detect virus.
Just to follow up on that, and I think Dr. Jeffries has summarised a lot of the diagnostic development, but in HIV, we've seen very good progress in terms of tests, as Dr. Williams is saying, which detect both the immune response and the virus at the same time, which are now routinely used and allow that early detection and narrowing the window. whereas that contrasts slightly with the development with hepatitis that was slightly behind.
And you use the term in your report seroconversion. Can you explain what that means?
That's just from going to be antibody negative to antibody positive, i.e. the detection antibodies that are specifically aimed against HIV being detected by the diagnostic assays that we use.
So the acute phase you have described as lasting a number of months. What is it that marks the end of the acute phase and moving into the chronic phase?
I suppose after the sort of seroconversion illness, there is what happens is there's a balance that is struck between the virus trying to replicate and the immune system trying to defend and develop an immune response. And so, as I said, and as Jane has also alluded to, the virus attacks the cells in the body that are specifically important for coordinating the immune response to any infection, which are the T helper cells. And these are very key in the coordination of the immune response, particularly adaptive and cellular immune responses. And so what happens is the immune system is activated, and it remains activated, and it tries to constantly generate immune responses to HIV. And in some people it can be very successful, in other people it's not so successful. Those where it's more successful, then the virus is better controlled and the viral load in someone is lower. Where it's less successful, the viral load is much higher. And to a certain extent, what happens during acute infection determines the natural history of HIV in an individual. So how your immune response responds to HIV during primary infection, during that acute phase, will determine your natural history, because it determines how well your immune system is coping with HIV.
And the timeline there, in general, that bit of the process takes about 6 months to get to a steady state. And so the arbitrary cutoff is that early infection is the first 6 months while these processes are going on, and the viral load stabilizes out to the viral set point. And that sort of marks the end of early infection, if you like.
Is it worth noting as well that with regard to this issue is that people are very highly infectious during that initial stage. So you've got highly replicating virus, and so infectivity, even though people may go for a test that is antibody negative, the infectivity is particularly high. Yeah.
So moving on then to the 6 month arbitrary 6 month point, where we're at the chronic stage. The viral set point you've mentioned can differ between people. What are the factors then that contribute to that difference? In your report, you said there are pathogen-related reasons and host-related reasons.
Well, I suppose in terms of age is by far the most important sort of host-related reasons, because as you get older, your immune system doesn't work as well as when you are younger, and therefore you're likely to develop a much better immune response when you're younger than when you're older. So age is definitely a factor in terms of that. As Graham has alluded to, there are certain people who have genetically more resistance to HIV in terms of they don't express the certain receptors on their CD4 cells that make it much more difficult for HIV. And there are other genetic factors that determine the person's immune response to HIV in terms of how well, like any infection. So if we take other infections, people can respond differently, in their immune systems can respond. We don't all respond the same. Genetically, we differ.
So in your report, you mention people with higher numbers of CD8 lymphocytes circulating, and people who express HLA-B57 markers having lower viral set points. Are those genetic factors?
Yes.
You've also, in your report, drawn attention to the presence of other infections having an impact on the host-related contribution to viral set point. Can you tell us a bit about that?
I think in terms of other co-infections, things like hepatitis B or hepatitis C don't have an impact in terms of how in terms of how the immune system responds to HIV. It has an impact the other way around. Generally, there aren't any other co-infections that will impact on the set point or on the natural history. There was data from a cohort looking at cytomegalovirus in terms of whether that has an impact, but that is not universally accepted. Generally, it's the quality and the strength of the immune response, which is genetically determined or age determined, that will determine the immune response to HIV. The subtypes makes no difference. Or the route of infection does not make any difference.
But I think I would just add that some other infections will also be challenging the immune system at the same time. And so you may be seeing the effect of two separate processes. And so that may in itself be accounting for maybe more rapid CD4 count decline, but it is not necessarily working through the viral load mechanism.
Yes, similar point. So I think you can see in the setting of another acute illness that someone's HIV viral load may rise transiently and usually come back again. But as we've heard, then sort of commonly recognised chronic co-infections tend not to have a big impact on that viral load.
Turning then to pathogen-related reasons, I think you said the subtype doesn't have an impact, but the type of HIV, 1 or 2, does that impact on?
Yes, I mean, everything we've written to should really be related to, the title should be HIV-1, yes. Not HIV-1 and 2. Yes. Because 2 is really a very different disease, and we see, it's something that only, in the UK, there's only, 200-300 people who are infected with HIV-2, and it's largely only seen in West Africa or people who come from West Africa. So when we talk about HIV, we're largely talking about HIV, we are talking about HIV-1.
And the other factor you mentioned in your report is the type of cellular receptor that the virus uses to enter the cells. It may be important as a factor in the progression of HIV. Can you tell us how that occurs?
Yeah, I mean, HIV needs, as the report says, the reason why it is able to infect T helper cells, which is the specific type of white cells that are important for the immune response, is that those cells carry a molecule called CD4, and it's the CD4 which the virus is able to attach to. But in order to gain entry into the cell, it needs another co-receptor, which are determined chemokine receptors, and just for technically, one's called CCR4, another one's CCR5, and the virus can use one of those co-receptors. Generally, a virus that is transmitted uses CCR5 bearing, is tropic to CCR5, but later on in the natural history of HIV, you can use CXCR4, it switches, but it's usually CCR5. But there are people who do not express CCR5, and they have a genetic deletion, which means they do not express CCR5, and therefore they are people who are less likely to become infected with HIV, but also people who their natural history is much longer. But they are really, as Graham said, this is a small proportion of in the UK.
And so over this chronic stage, then, what's happening to the virus and to the immune system?
Okay, if I can. Usually when the immune system responds to an infection, it is activated, and then once the infection is gone, the immune system goes back into a resting state. But in HIV, that doesn't occur because the immune system is constantly responding to ongoing viral replication to other factors. So the immune system is in a state of hyperactivation and inflammation. If I can give you a sense of if you were going to the gym and you're running on a treadmill, you could run quite walk quite comfortably for a long way. But if you're having to run at a very high level, you get exhausted much more quickly, and that's what happens with the immune system. It basically is in a state of of immune activation at a high level, because there's this constant level of replication of the virus. So the patient remains clinically well, but there's ongoing viral replication, and so you're in a state of high inflammation and high immune activation.
And can I, Henry, ask you to pull up on the report, page 6, table 1, please. First of all, can someone tell us what this table is, what we're actually looking at here?
So this is one of the classification systems used internationally for HIV infection, and this is the one from CDC, the Centers for Disease Control in America, and is probably the most commonly used classification to try and describe where along the spectrum the infection has got to, going through some of the stages we've already discussed. There are a number of classifications. The WHO have got one, but this is the one that is the most commonly used when we're referring to where in the stage of infection people are. So we've been talking so far about acute infection, early infection, where here we're talking about category A, which is the first column. Then we're talking about this latent period, if you like, chronic infection, where we're talking about B. And then we get to a point which is classification C, which is where the HIV infection has now caused enough damage for somebody to get sick with a variety of particular clinical conditions, which allows a diagnosis of AIDS to be made. Now, in addition to that, there are the ability to put in the numbers of CD4 cells to modify that classification about whether somebody's got a very robust immune system, which is with a CD4 count above 500, or whether they are already in a place where the CD4 count is very low, i.e. below 200. So this is really, I suppose, the international shorthand that is used in the world of HIV classification. It's probably I would say it's used much more as perhaps a public health and epidemiological tool, as a way of charting what's happening and allowing you to compare populations. It's also important for an individual patient to give them a sense of where on the spectrum they sit. So this is the recognised international classification.
So in this chronic phase, this middle phase before AIDS is diagnosed, as I understand your report, somebody could be showing no symptoms, or somebody could be showing one or a number of the symptoms that are listed there in clinical category B.
Absolutely, yes.
And presumably people could move from no symptoms to symptoms back to no symptoms.
Yeah, although on the whole, if somebody's moved into early symptomatic infection, often there's something grumbling around. It's a sign.
Once they've gone into category B, and that's an indication that their immune system has been damaged quite significantly, and so they can't move back to being asymptomatic.
Yeah.
It's probably worth just mentioning briefly again about the viral load and the CD4 count. So we've talked a bit about T helper cells, and when we talk about CD4 counts, we're talking about a blood test which gives an estimate of the numbers of the concentration of those CD4 cells. So a patient may be well and not have symptoms, but their CD4 count may be declining, and that's something that can be monitored. And that tends to be the most useful test we can use to monitor that phase. The viral load is often measured, though these days patients would usually be on therapy, but the viral load can give you some sense of progression risk, but it doesn't tend to be what we use to monitor where things are going. CD4 count is the thing that's used mostly.
Yeah, and I think that's also important. In the States and in some other countries of the world, just having a CD4 count below 200 allows a definition of AIDS to be made. In the UK, you are required to have one of these clinical indicator diseases as well. So that's a difference between the American classification and ours. Although in actual fact, I think in practical terms, it probably makes little difference, because as Graham's saying, by that stage your immune system is weak and you are susceptible to major infections.
And when you talk about the clinical AIDS defining diseases, what you mean is one of those in category C.
Exactly,
Right, yes.
exactly.
And it might just be worth noting that although the classification doesn't change, you stay in that category. Of course, on a practical level, you may well have medication and treatment that makes you feel better. Your symptoms are less, but the classification remains
Exactly.
the same. So, you know, you as a person may be treated and do not feel as sick as you were before, but your immune system is still very compromised.
And this, of course, presupposes this is without antiretroviral therapy. This
Yes.
is the progression as
Yes,
untreated infection.
yes.
And forgive me, we didn't put it into the report, but there are different classification systems for children who, by and large, had rather more rapid disease progression than adults. And the CDC came out with their classification system in 1994, and WHO revised that in about 2007 with a very comprehensive view of pediatric HIV. It's different to this, but it does fall into the similar kind of categories of ABC.
And again, the sort of acute, chronic, and then AIDS.
Yes, I mean, recognising that actually in children it was even less common for the immune system to mount an effective response that produced symptomatic disease, and indeed a less effective immune response that brought the viral load down, so that in perinatally infected children we were still seeing viral loads above 100,000 very commonly 2 years after age 2. But again, as you go through childhood, beyond the age of 5, the CD4 counts broadly fall in line with adult CD4 counts. Below 5, children have very much higher lymphocyte counts and CD4 populations. So we had a whole different series of thresholds for recognising severe immune suppression in children. But we haven't put that all into the report. I'm very happy to provide it in the supplemental report if that's felt to be relevant.
So for children, it takes them a lot longer because their immune systems are immature.
No, I wish that was true. No, quite the opposite. Because you've got so many target cells, HIV replicates very, very efficiently in young children. No, the fact that you've got more higher CD4 count just means that we had to adjust the thresholds. I remember very clearly being told by my adult colleagues when we were diagnosing AIDS-defining conditions like pneumocystis carinii pneumonia in children with CD4 counts of 1,200, and my colleagues would say, "Oh, don't be stupid, you paediatricians don't know what you're talking about." Actually, it turned out that the average 6-month-old ought to have a CD4 count of about 3,000, and so 1,200 was already severely immunocompromised. With all due respect.
Turning then back to the clinical category B, can we, because the inquiries received and heard a lot of evidence about the different experiences that people had in the early days of HIV infection. Can I ask you to go to explain what these clinical conditions are and how they would be experienced by patients and what the treatment for them would be, and again, what the symptoms and side effects of those treatments would be?
And you're talking here particularly about the things that don't reach a classification
Yes.
of AIDS.
I'm talking here about the clinical category B matters that are set out in this table 1.
So there's a variety here of conditions that are coming into play because the immune system is weakening. And it will depend, again, on each individual person, which of these conditions comes to the forefront and which ones they experience. So there are some particularly common things. Shingles, herpes zoster is quite a common thing for people to experience early on because most people have at some point in their lives had a chickenpox infection. So it's a common virus that's in most people, and actually it's quite pathogenic, so you don't have to be that immunosuppressed for it to reoccur. So it's one of the things that can come quite early on in category B, if you like, because it's quite a powerful pathogen, it's common, and you don't have to be that immunosuppressed to find it. We noticed things like, I've put here, we have here idiopathic thrombocytopenic purpura. That's when your platelets in your blood are low, and that's probably an autoimmune problem that's going on in the background. So people might notice easy bruising, or on a routine blood test, oh, the platelet count's looking low. The patient may actually not necessarily notice that, but it may come up as a signal, if you like, that there's something going on. The sense of constitutional symptoms, people talking about just really not feeling great in quite a non-specific way. And in those, certainly in the days before antiretroviral therapy, it was not uncommon for people to talk about sweats, particularly night sweats, fevers, and feeling just generally out of sorts and not well in quite a non-specific way. Infections of the skin are quite common, and flaky skin, seborrheic dermatitis on the face, quite common, and infections of the mouth like thrush and viruses that can affect the tongue, causing oral hairy leukoplakia, which is an Epstein-Barr virus. And they're all quite non-specific in that setting, but they are indicators of an immune suppression going on in the background. So many of these now, and we come to this a bit later in the report, could be, if you like, indications as signposts, signalling conditions. People who maybe go to their doctor with some of these conditions should be ringing alarm bells that there's something else in the background. But these are often not particularly specific to HIV, but they're there as a marker that the body is not strong and something's going on in the background, if that starts.
And in the 1980s, were treatments available for most of these conditions?
In the 1980s, it would depend, it was variable.
1990s?
Some of them, but limited, I think. There was acyclovir would have been available, which would be a standard treatment for shingles, herpes zoster, and some of these would have responded to standard antibiotics like penicillin. The more common things, and thrush, I think, in fact, there would have been some therapies, but when we come on to talk about the conditions of more advanced disease, those therapies were ones that needed to be developed specifically for HIV infected patients. So of this list, I would say that actually probably most of them had some treatment available.
But I think things like constitutional symptoms, which are really disabling, things like feeling very tired, diarrhea, weight loss, night sweats, they weren't specific treatments for that because they were the direct effect of HIV damaging the immune system. Things like peripheral neuropathy, which is numbness in the feet, again, they were direct effect of HIV. And so it's only when antiretroviral therapy came along that made a direct effect on those. Where you had a co-infection, say, with herpes zoster or with oral candida, then that co-infection can be treated, right? But the constitutional symptoms were very difficult.
It's worth pointing out that there's a second page to this, to the document that's on the screen at the moment.
Yes, can we go down to the next page?
Yes, you've got.
Thank you. Yes,
Candida.
thank you. So there are more conditions there on that second page. Can somebody speak to those?
So we've talked briefly about thrush in the mouth, and again, people can get thrush in the mouth for a variety of reasons. But
So fluconazole was available.
Nystatin mainly.
We'd have used nystatin mouthwashes, amphotericin mouthwash, amphotericin lozenges. Do you remember those?
Yes.
There were things, and actually sometimes caniston pessaries we would use for people to suck, and it would be often give people a very sore mouth. It would be very uncomfortable. White tongue, white around the cheeks, lining the cheeks. And the same for vaginal candida, again, more difficult to treat than you would expect it to be, recurring, not shifting. And yes, there were certainly treatments available for vaginal candidiasis, but not as effective as they are now, that's for sure. Cervical dysplasia got added later on. As it became more women became affected or were living with HIV, it became clear that more of them had got cervical abnormalities on smear tests. And again, they would have had standard treatment for cervical dysplasia at the time. Now, with antiretroviral therapy, often those cervical changes go once a woman starts antiretroviral therapy. Peripheral neuropathy, I think, as Ian's alluded to, often really hard to treat, and pain, we would have used a variety of, we've sometimes used amitriptyline in those days. There were not great specific treatments for people at that point.
Ms Edwards, did you want to add anything about nursing people at this stage of their HIV?
But I think the expression earlier is about these constitutional symptoms were so very difficult and so debilitating in many ways. You know, oral candida, for example, is probably the classic, because I know it looks awful, it's awful to treat. It stops you eating, you know, it looks horrible. It's a very psychologically difficult thing to deal with. And of course, people, although other people get these infections, these people with HIV, their immune system wasn't improving, so they kept coming back. And it's not one, you know, you're not getting one of these things, you're getting one or two or three of them. And my certain memories, and I'm sure lots of memories of the night sweats, that was really bad. You know, the night sweats at night, waking up drenched, candida, diarrheas and things, you know, and this was before opportunistic infections really hit in. This was the early days of infection. So yeah, very debilitating and psychologically difficult.
The other, in terms of things like herpes zoster, which is shingles, as Sean said, it would become recurrent. But the impact of shingles can leave you with very difficult to treat neuropathic pain, which is really debilitating. And it's not just the infection that you can, of the herpes zoster that can be treated, but it's the consequences that really are quite impactful.
And you've mentioned the psychological difficulties. Presumably knowing what's coming, what this means, adds to the burden tremendously to those that were suffering it.
Absolutely, yes.
Yes. So I was going to move on that now to the AIDS itself. And
Well,
so
it sounds like something that we'd better deal with at 12 o'clock, do you think?
Yeah.
So, 12 o'clock. Yes.
So we were going to move on then from the chronic infection stage, the middle stage, to AIDS itself. And you've already given some evidence about how you diagnose AIDS. And we were looking at the table, the CDC table, which sets out the clinical category of a C of AIDS-defining illnesses. And you've explained that in order to meet a diagnosis of AIDS in the UK, you need to have one of those AIDS-defining illnesses. Is that right?
Correct.
Can you just say a little about, in your report you explain that the way that HIV relates to a person's immune system is reliant on three factors: the microbial exposure of the patient through life, the pathogenicity of organisms encountered, and the degree of immunosuppression of the host. Can you just explain why those three factors impact differently and give people different experiences of HIV going through to AIDS?
So I'll kick off on that. So from what we've discussed so far, I hope it's become clear that the things that happen to people living with HIV are a consequence of the immune system weakening. Now, all of us have been exposed to microbes and germs during our lives, and many of us have got different exposures depending where in the world we've been or what we've had in our lives. And many of those infections may stay with us. and we don't know we've got them and everything's fine until the immune system weakens. And then some of those things that we've been able to keep in check come back and re-emerge. So, for example, a particularly prominent one might be tuberculosis, and that then may be much more common in a person who's lived in an area where there is a lot of tuberculosis in the first place, whose immune system becomes weak enough for tuberculosis that may have been around for a while to emerge, and the pathogen itself, the problem that's going to emerge, how powerful it is. So a very powerful pathogen doesn't need so much immunosuppression to appear, and it will depend if you've met that pathogen before. So one particular example for which we could use perhaps is cerebral toxoplasmosis. Now that's an infection that lives in meat, and actually if you look across the world, people in France who are used to eating meat that is rare often have got much higher levels of having met toxoplasmosis in a previous life than other parts of the world. So that's where we're thinking about the microbial exposure. If you've met toxoplasmosis in the past, then your immune system becomes weak. That is something that is going to come back with a brain abscess most commonly. So when and I'm thinking back now, sometimes people will come with very undifferentiated symptoms. Somebody will come with meningitis, which just suggests an inflammation of the brain. So which sort of meningitis is it going to be? Well, where maybe have they lived? What exposure might they have had? How immunosuppressed are they? So those are the sorts of questions that would have guided the diagnostic process, if you like, in trying to work out what's happening. The more pathogenic things are happening at an earlier stage, and for example there's a particular bacteria called Mycobacteria avium intracellulare. Normally it doesn't do anything much at all to people, but once the immune system is so flat, then it can emerge and cause a problem. So that's something you would see probably much later on in the course. So it's trying to have a balance as you're thinking this through of what somebody might have met before, where they are on their immune system spectrum, and what sort of pathogen power there is. But of course, by the time somebody's experiencing something from this list here, these are all things that really only happen when the immune system is really weak. They're a way of signalling how weak the immune system has become, that somebody is able to have this as a problem in their lives, if that sets the scene.
Yes. Henry, can we turn to table 2, which is at page 33 of the report?
I think the other thing I would just say at this point is that if we think back, making a diagnosis of what it is that's the problem is absolutely critical here, because if you don't have antiretroviral drugs to deal with the underlying HIV, then the work has to be done by the drugs you do have to treat whatever infection or tumour it is that's causing the problem. So the work of making a diagnosis is really important, and so people would have gone through a lot of different tests and a lot of examinations to try and find out what pathogen it is if you can't deal with the underlying HIV itself.
Sorry, Henry, can we go back to the previous page, the page, yeah.
And it's just worth making the contrast to what we were discussing earlier about some of those more common conditions where there were some treatments. I mean, many of these that we're going to go through are very severe conditions for which many treatments didn't exist, certainly in the 80s through to the 90s and even quite recently. So the diagnosis was crucial, but there was often a limitation in what could be offered in terms of intervention.
So I understand from your report that there's now effective therapy for HIV, and so these kinds of conditions we're going to look at now aren't appearing in this country in any event. But certainly, Inquiry has heard evidence of people suffering these conditions, and so can we do the same exercise? Can we go through the symptoms here caused by the major HIV-associated pathogens and look at how that would have impacted people and the kinds of treatments, if any, that were available and the burden of that treatment on them. Can we start with candidiasis, please?
Well, I think Sian's already alluded to how painful it can be to have thrush in your mouth, but if your immune system is even weaker, then it can spread down into the esophagus, which is the tube where you're swallowing food. So a very common complaint, people would talk about how difficult it was to swallow, to eat, a feeling of food being stuck, and pain, real pain as you're eating. And then that would be, I guess, a bit more common, but you could actually find thrush getting into the lungs, which would make you cough, short of breath. So imagining a sort of layer of fungus going through the hollow tubes in the esophagus and the bronchi, which really pain, discomfort, difficulty breathing, and I think what you said earlier, the impact on appetite and your ability to enjoy food or eat properly. I don't know if, Sian, you might want to add to
I
that.
don't think there's anything to add. Yes, I mean, I think most people who had AIDS actually had a candida. It seemed incredibly common. And of course, when people are sick, what you want to do is feed them. No one wanted to eat. And, you know, there's many, many reasons, including the virus itself, that people lost weight. But the extent of weight loss amongst this group of patients was extreme and debilitating and extraordinarily painful for family members to watch.
And even in the setting of advanced immunosuppression, even a condition like candidiasis can be fatal. So you can have bloodstream infection, which can be fatal. And many of these conditions will go through, we talk about symptoms, but in their most advanced conditions can be fatal.
And when it gets to this stage, was there effective medication?
There are usually medications now for this particular condition, candidiasis, that would be effective. We're seeing more resistance these days to some of these medications, but generally speaking, but these are really relatively recent treatments that are available now.
And going down the list then, cryptococcal infection.
So Cryptococcus is it's a fungus. It most commonly in the context of HIV infection would cause meningitis, a particularly nasty meningitis. So meningitis would then often present with in this particular circumstance, awful headache, change in conscious level, very debilitating. And one particular feature of Cryptococcus is it sort of clogs up the fluid around your brain, can't flow properly down and away. So people would get the hydrocephalus and very complex meningitis from a cryptococcal infection.
Yeah, and the treatment required repetitive lumbar punctures to decrease the pressure, which was highly invasive and discomforting.
Yes.
And a consequence of if you didn't do that properly was blindness. People would lose their sight. So cryptococcal infection is one of the most severe opportunistic infections we see with a high mortality. And getting it early was very important. People presenting late had, their outcome was in the early days was not very good.
And I would also add the treatments for fungal infections. They've advanced a lot, but the sorts of treatment we might have had available when we were seeing a lot of, they were really unpleasant for terracin, very toxic treatments. So even if there was an antifungal agent that you might want to use, it would have been very unpleasant.
And it's also a really good example of a pathogen that's prevalent in the community.
Yes.
You didn't have to go further than a London park because pigeons and pigeon poo particularly was implicated in the spread of cryptococcosis. And again, it comes back to that idea that probably all of us in this room who've ever walked through London Park have got exposed to cryptococcus. But if your immune system's working okay, it doesn't cause any problems. But if your immune system is damaged, it causes this really debilitating meningitis.
I don't try and pronounce the next one down. Does somebody else want to have a go?
So
Cryptosporidiosis.
cryptosporidiosis. And again,
Can somebody
another-
speak to that?
Well, again, it's another one of those infections that really indicates very, very profound immunosuppression. And it's again, as Gareth has said, it's a thing that's knocking around in water supplies in any event. But we would see it in the context of HIV often really debilitating, causing terrible, terrible diarrhea, very watery diarrhea, which was sometimes with crampy abdominal pain, but the cardinal feature was that people lost a huge amount of weight and fluid and really, really intractable diarrhea. And I think the nursing issues around cryptosporidial diarrhea were really profound, and it was a horrid, horrible infection to have.
Ms. Edwards, do you want to add anything to that?
I think it's this was the word. I'm actually sitting here listening to this, and memories are coming back. And I was a nurse, so I can't imagine what people out there are feeling. Going through these is quite, I think, possibly quite traumatic, because I think memories of how people, because as I said earlier, it isn't one. People had candidiasis and they had cryptosporidiosis, and they had something else, and it is a ruthless, in some countries, it's a ruthless disease. And the impact, certainly, of cryptosporidiosis from a nursing and medical point of view to try and control this intractable diarrhea meant that people couldn't go out. They couldn't leave a toilet. It was a dreadful disease, which was very difficult from a medical point of view to control. And again, the families, it was a very hard thing to watch and care for people who had this condition, which was again common.
And we really didn't have useful treatment.
No.
And probably it's the best example of where we still really don't. And the thing that's transformed what we can do is the advent of the HIV treatment itself. And, we still have very poor treatment for cryptosporidiosis, and we desperately need it.
CMV?
Where should we start? CMV, goodness.
So,
do you want to, Graham?
So CMV is a viral infection. It belongs to a similar family to glandular fever, and many people are exposed to it from early in life and increasingly exposed, particularly through adolescence and early adulthood. And again, it's an infection that many of us handle without any great problem if our immune systems are good. But in the setting of progressive weakening of the immune system, that virus can reactivate, and it's the reactivation of that virus that can be very debilitating. And often with advanced infection, one of the more common things we used to see, and thankfully see much less of, was damage to the back of the eye, which could really affect vision. And it's a good example of something that could then be long-term, even with effective treatment and recovery of the immune system subsequently. You can see reactivation in other parts of the body where it can also have very devastating effects in terms of the gut, and you can have a very inflamed gut, colon and diarrhea, which can be very hard to treat and painful. Reactivation at the upper end of the gut in the esophagus, where it can be very painful, and then reactivation in the lung as well, where not a bit like a pneumonia, but you can have inflammation in the lung, which can make breathing difficult and getting oxygen in. It is an example of where we actually have got much better treatment now, but some of those earlier treatments that we used were very toxic, and so again it's the sort of recurring theme of individuals who had very advanced HIV, very sick, with really the only options for treatment being very toxic medications, which we were obliged to use really.
And because of the toxicity to the veins, we often used to have to implant what are called portacaths. So a person might have an indwelling venous access, which would often be on the chest wall, so that the drug could go into a big vein because it would be too damaging to the veins to go into the arm. And so often people would have to have a surgical procedure to have a thing called a portacath fitted, and then that needed to be looked after and managed, as well as getting the medication in as well. So it was really complicated.
And also cytomegalovirus is a really big issue for pregnant women. And so in the context of HIV, that was a co-infection that we saw really too commonly in the infants born to mothers who were HIV infected. And just remember treating far too many children who had gone blind as a result of HIV and CMV co-infection. And I'm sure you remember that in the London Lighthouse, there may be people in this room who were involved in planting a garden that was full of different sensory plants with really lovely aromas because retinitis had blinded quite a number of people who were inpatients at the London Lighthouse. And I always remember thinking that was a tremendously wonderful, humane response to what was a terrible co-infection.
I think this is really the impact of CMV in the eye. They would get one episode was treated, they would have to remain on treatments to try and prevent relapse, but then they would then get another relapse, and at each relapse there will be loss of vision. And so many people who developed CMV retinitis, before they died, they went completely blind. It was a really debilitating, horrible thing.
Encephalitis?
Well, not much better. So HIV, we know, can directly affect the brain, both in acute infection and chronic infection. And that can lead to quite a significant clinical manifestation of confusion or even more progressive cognitive sort of challenges with thinking and memory and so forth, which in advanced HIV could be very profound. And even with the advent of effective HIV therapy, not always reversible. So it's still an issue that we have to contend with in clinics today, often to a milder degree, thankfully, but nonetheless still something that's sort of an active area of interest in particular.
You touched on herpes zoster earlier, but here we have herpes simplex. Is there anything you want to add to that?
Well, herpes simplex is an infection of the skin, the genitals, of the mucous membranes. You don't have to have had chickenpox to get it, so zoster is related to the chickenpox virus, but herpes simplex, many people have it, and it doesn't cause problems, again, until the immune system becomes weak. But it's one of the ones that's quite a powerful pathogen, so again, it would come quite early, and I think the level of painful ulceration, and again, if you've got some oral candida and herpes simplex on the mouth, exquisitely, really painful and very difficult often to manage. So again, it would be one of the things that we did have some treatments which you might then ask somebody to take long term to try and keep it under control. So again, adding another layer of medication, both to treat and to try and prevent recurrence.
Histoplasmosis?
So it's another relatively unusual infection in this case, but again, we do see occasionally in people who have healthy immune systems, but relatively rarely. But when it did affect people with advanced HIV, we don't see it very often these days at all. And now, fortunately, we have better treatments for it, but it was a condition which had a very bad outcome in the setting of some of the treatments we had available at that time. And these antifungal drugs we've already mentioned were often, when they were available, quite difficult to take and to use. So fortunately a condition that we see much less of, but nonetheless often very serious, if not fatal.
Kaposi's sarcoma, that's something you've said in your report is not something that's seen very much in those that are infected through blood and blood products. Is it seen in that cohort of patients?
Depends on lifestyle. It depends whether people have been exposed. Again, it has a viral origin. It's related to some of the other herpes viruses, so it can present itself, but it's much less common. But when it happens, it's on the skin. It's very prominent often. People have lesions that appear that are very easy to see and can get into the gut and into the lungs and cause severe systemic problems as well.
It is, of course, the early look of AIDS that many films are based on, with people who have these purple blotches all over their bodies and skins, and was deeply stigmatising for people. And if there was any way with some of these things you were able not to be known as having HIV infection and AIDS, if you had Kaposi sarcoma, there's no way.
If my understanding is right, then it was Kaposi sarcoma that was a particular identifier of the 5 adults who gave rise to the first report in the Western world of AIDS.
Indeed.
And I think, am I right in thinking that it was because of a specific drug that was really only used for that the CDC was able to investigate why that drug was being used so much in that particular part?
That was pneumocystis.
All right.
The next one along.
But they came together.
They came at the same time, and people would often have both.
Thank you.
Lymphoma?
Lymphoma, where should we start? Yes, so lymphoma is it's a cancer. It's a cancer that has it's got an infectious etiology, but again, we're seeing it much more commonly. And these are cancers that can occur in people without HIV, but much more common with HIV. And the fact that I think that the CNS, the brain, the lymphoma that affected the brain, particularly relates to co-infection with HIV. Hard to treat, and again, going back to some of the chemotherapeutic approaches, some of the oncology approaches, it was often fatal.
I think the other thing about lymphomas are seen in people who have other immunosuppression, so people who have had transplants who get a much higher risk of lymphoma. And in the early days, lymphoma, when it usually presented with advanced lymphoma rather than early, and therefore the outcome of treatment was often very difficult, was very much worse. But lymphoma now, treatment of lymphoma in someone who's HIV positive, the outcome is no different to someone who's HIV negative. There's been, a marked improvement in that.
Can I just invite you to look down the rest of that list, and are there any of those symptoms or pathogens that were particularly prevalent for those that have been infected by bleeding or blood disorders, or that you would like to talk to because of the burden of treatment or the burden of the condition?
I think we have to include pneumocystis here, because that was probably one of the most common AIDS-defining conditions, and that is the one that you're referring to. Lung infection, most commonly, although it could affect other parts, and often very slow to present itself. So quite a long time feeling short of breath, bit of a cough, not necessarily that much tea, but actually by the time people came to medical attention, often very short of breath, feeling it was a very uncomfortable sensation of not being able to breathe, and shortness of breath on exertion, and perhaps one of the commonest opportunities.
And earliest.
Rather than affecting the lung airway, it was affecting the lung tissue and preventing gas exchange, so that certainly the children I looked after had very profound low levels of oxygen, which makes you feel horrible. And it was all part of that systemic illness.
What I would say is that we quite, even before we had very effective antiretroviral therapy, it became quite clear that taking regular low doses of an antibiotic called Septrin could actually help prevent this occurring. And so, again, another drug that you might add in, not to deal with the HIV, but to try and prevent this particular infection, but would add to the burden of medications that people might be taking. And people with HIV often had higher levels of allergies to drugs, and Septrin in particular would be something people would start Septrin and come out in a rash and have a drug reaction as well as everything else.
And the evidence the inquiry has received from some of the people who experienced some of these conditions and then recovered and are alive today is that they suffered ongoing damage as a result of these conditions. So despite having been cured, they continue to exhibit symptoms. Is that right?
And I think that's particularly true for a couple of the conditions we haven't dealt with. So progressive multifocal leukoencephalopathy and toxoplasmosis are both conditions that affect the brain caused by different pathogens that reactivate in advanced immunosuppression. But I still have patients in my clinic who are now relatively well with dense strokes from conditions like this. So very profound long-term disability that can result even when HIV can be treated.
Yeah, so CMV, Cryptococcus, toxoplasmosis would all have long-term, lasting sequelae, even if the acute episode had been dealt with.
And it may be just worth noting that, as Joan said, that each of these things, it's not one, it's many, and for all of them there are treatments that are being tried and trials that are being tried on some of these infections in these early days, but the treatments themselves were often very, very difficult, so there were further treatments like anti-nausea treatments and such like to counteract the side effects of treatments. So it's just to sort of put into perspective that people are very sick with multiple infections, with multiple treatments and side effects and constant. So the amount of treatments that people were taking was extraordinary.
And I think following on from that as well, the numbers of times people would be in hospital.
Yeah.
So this would, you have something would happen, you'd come into hospital, you'd have an episode of treatment, go home, come back with something else. So there was a lot of people coming back and forth, as well as the treatment they were on, but hospitals as places of people coming back and forth to much more regularly.
So people might present with pneumocystis, and you might be able to prevent that again, but then they may then present with cytomegalovirus retinitis, and you need further treatment for that to prevent that, and then they might present with toxoplasmosis and stroke, and then lastly present with MAI. So there was a series of very severe opportunity infections that required preventative therapy and treatment, but also very debilitating.
You've also, in your report, drawn attention to the fact that there are other health complications which are observed in those that have suffered from HIV. I'm talking paragraph at page 25. So other than the AIDS-defining illnesses, you observe that there are other health complications that are observed. And one of the ones that you draw attention to is epilepsy. Which can develop independently of HIV, but also be linked to it. Can you tell us a little bit about that? It's the second paragraph down in page 25.
So epilepsy is a seizure disorder, and there can be multiple causes of seizures. So I think what we're trying to draw attention to here is that there are many of the clinical conditions we've been discussing here which would be related to seizures. Cryptococcal meningitis, toxoplasmosis, lymphoma could all have an element of seizure activity around them, and somebody may also have epilepsy, idiopathic epilepsy, as well, or separately. So I think that the sense that we're trying to draw attention to here is that you may find some of these sorts of disorders in parallel.
Yes.
I think it's worth clarifying for epilepsy that really we think of it as you're saying, as a consequence of brain infection and a focus of brain infection generally in the HIV-positive population. Clearly, anyone can get epilepsy, and it's relatively common in the general population. But in the absence of an aggressive brain infection, then it's relatively uncommon. It probably wouldn't be of greatly increased prevalence.
I mean, certainly from a paediatric perspective, and I think it's true in adults, that HIV per se, the encephalopathy associated with the HIV virus, did not cause seizures. It usually suggested there was something else going on.
Yeah.
And that was one of the problems, that you then do a CT or, I can't remember when we started doing MRI scans, but you'd see a lesion inside the brain that would be the likely cause, but you didn't know whether that was lymphoma or toxoplasmosis, and you'd take an educated guess and you'd treat the toxo, and if it didn't go away, then you presumed that it was probably lymphoma. I mean, it was not, it doesn't lend itself to doing biopsies and getting tissue diagnoses. It was a really big diagnostic challenge back in the early 90s.
I'm not sure if we're going to go on to later, but the other important thing, these are the AIDS-defining conditions,
Yes.
but There are other HIV-associated comorbidities
Yes.
which became much more apparent as treatment became more effective.
Yes.
I don't know whether you wanted to...
Yes, now would be a good time. That was my next question. Yes, can you tell us about that?
Jane?
Well, so we're now in the position that if you can, with antiretrovirals, ensure that the immune system remains strong enough for the things we've been discussing just now to not occur, then there is time for other things to begin to emerge, which in the early days we didn't necessarily see because people died of some of the things we're talking about now. And it's clear, I think, one of the things that Ian referred to earlier is that with HIV, the body's in a constant state of inflammation, if you like. There's an excessive amount of inflammatory response going on. And that seems to predispose to higher rates of cardiovascular disease, some of the metabolic disorders, bone disease. So there's a link between viral activity and inflammation. On top of that, we know that that there are some behavioural aspects. So more people living with HIV tend to smoke, and that may predispose to some of these other, maybe some lifestyle issues as well. And we also know that the medications that are used in the treatment of HIV and its complications can themselves precipitate, particularly bone disorders are particularly common. So we see more long-term chronic conditions now because people are alive and this sort of low-grade inflammatory response is continuing.
Treatment is very effective in terms of getting the immune system better, but there is still ongoing background of inflammation, and that inflammation is thought to drive some of these increases in risk of other chronic diseases of aging, such as kidney disease, such as heart disease, such as lung disease, and of cancer. So we are seeing far more increase in other non-AIDS defining cancers, like lung cancer is more common in people, skin cancers. And cancer is now by far the leading cause of death or mortality in someone with HIV, not the AIDS-defining conditions. Equally, if you look at cardiovascular disease, HIV is felt to be equivalent to smoking in terms of risk of cardiovascular disease, to give you a sense of the risks.
And the increased risk of these other health complications is increased as against the HIV negative population.
Yes, absolutely. So yes, we've dealt with very effectively in terms of improving the immune system, but we're left with a population where they have a much more increased risk of other chronic diseases of aging compared to the HIV negative population. So although life expectancy has improved, this is often associated with increased frailty and impact of quality of life.
And do you know what the increased risk is? I mean, I know it's on a population level, but increased risk is as against those that don't have HIV.
Well, in terms of, for example, cardiovascular disease, then there's a sort of it's the same as if you were a smoker.
Yes.
So, if you are a smoker, then your risk of cardiovascular disease goes up. In chronic kidney disease, your rate of decline in your renal function is faster than in someone who's HIV negative.
So you've set out the burden, if I can put it that way, of the virus itself, the AIDS defining illnesses and the invasive treatments for those, particularly in the 80s and 90s. The treatment for the medication for the ART antiretroviral medication and these other associated health conditions. Can we talk now then about, and we've touched on this, the psychological impacts of having HIV and AIDS, and again we've touched on the stigma of that as well.
Sian, do you want to? Where should we start, David?
Well, I think in the community, for people to live with HIV, if we remember back, and I often think of the adverts that were on at that time, there was a huge stigma associated with it. I think if we think of perhaps the coronavirus now, and then think of the people who get coronavirus being somehow stigmatised, it's that sort of thing. So there was a huge stigma attached to that. Dealing with a chronic, life-shortening illness obviously has psychological an impact, and then you add to that dealing with it's like putting a stone in a pond, the ripples out, so you're dealing with your family, you're dealing with the lack of support, the lack of perceived sympathy from a wider population sometimes, and against a background of almost national hysteria. So all the elements were there, I think, to really make for a very psychologically damaging and difficult time, and all of that enhanced the stigma that was associated with it.
And just to add, and I think Gareth can do this better than me, but of course the people that we're dealing with are often children and adolescents who were going through, as we were talking about on Tuesday, huge changes in their own lives and separation, which should have been a healthy separation from families, parents, and trying to build their lives and their futures, which, when we have just described what some people were going through, was near to impossible, and also created a great dependency, of course, on the family. But maybe Gareth can talk more about that. But it's really important that we think that many of us dealt lots with adults who are infected, but there is a high proportion of these young people, children and 16, 15-year-olds.
No, I like David's analogy of the ripples spreading outwards. Certainly we've seen, I mean, we're always at pains to point out that if a child was not infected, were they okay? No, they were affected by what was going on within the family. So, yes, it's a very real issue.
I think we really can't overestimate the impact of psychological problems in someone who's HIV positive. It really is something that is core and runs through the whole life of someone who's HIV positive. Some people will adjust to that diagnosis quite quickly. Others take a long time to adjust to that. Even in surveys of Positive Voices, a survey produced by Public Health England, even now looking at the incidence of mental health disorders, it is 30% in the patient population with HIV compared to only a few percent in the HIV negative population. So it really cannot overestimate the impact of mental health problems.
Absolutely.
So,
Sorry, I was just going to say one other thing, and I think that is the issue of stigma, which
Yes.
again we talked about on Tuesday in great depth, and mentioned is that people hid away. And so most people, when you have a ill health, you see your doctor, your nurses, your community, and you are able to share this pain, whether it be physical or psychological, and you get support, and people care and sympathise. And HIV is unusual and awful because of the fact that so many people were unable to do that sharing and often lived in isolated communities and were unable to share what they were going through, and the psychological burden on not being able to share the pain psychologically or physically that going is huge for people.
And that in the next, I would add to that the sense that the fear that you might transmit or pass the HIV on to somebody else might actually make people go into themselves even more and avoid forming new relationships, and so becoming even further isolated.
and the impact of going through those psychological and emotional processes while one is physically unwell, what is the impact on one's physical health of those mental, psychological and emotional difficulties?
Well, sorry, just before we go on to that, I would also say for the wider family members, because quite often people who had HIV and subsequently AIDS and would have been seen at that time as having a terminal diagnosis came home to die, and they often came to more isolated communities or where there was even more stigma attached, and those people subsequently died, and that left a huge impact on their family. So not just for the people who had the illness, but for the family, and I think that continues to this day. I certainly know of families where they've lost a loved one, and that still has a huge impact. So sorry, to return to your specific question, I mean, the whole gambit of mental illness, obviously depression, think of cases of self-harm, right up to suicide, absolutely. And again, I think for the whole family circle, because people did feel a lack of support, perceived a lack of support. I think healthcare professionals, sometimes we felt powerless, and that may have transmitted to people feeling that we, even in extreme cases, didn't care. But sometimes it was the lack of support. And because people didn't neatly fit into a particular area where they could be referred for treatment or whatever, so you might have been depressed, but then you were referred maybe to mental health services, but it was sort of thought, well, this person has HIV or AIDS, so that's obviously the cause of that, and that was sort of almost compartmentalised. So again, an actual lack of support and a perceived lack of support meant that those mental health outcomes were perhaps worse.
I think one other thing as a community nurse, I think I have to acknowledge the fact that we were attached to big specialist centres often, and where that did exist, sometimes the care and support was there, and we were able to help people to an extent, but outside those specialist centres into the more rural, regional, sorry, I'm using my Australian terms now, the regional areas of the UK, sometimes the support and the medicine and the doctors were not there. That just was not, and the ones that were there may not have had the education and the knowledge, and so people were let down, and so they had to survive in a family unit, often alone with very little support.
And I think it's important to remember this was the pre-internet age, which of course has revolutionised, and people can keep in contact with self-help groups and other people who are suffering in a similar way. People really did feel very isolated at that time.
But I think there's also, there's still some truth in what you're saying today. We know, as Ian's alluded to, that the burden of mental ill health is higher amongst people with HIV. Actually, many of the specialist centres, we ensure that we have psychologists on the team. We have very close working relationships with our mental health colleagues, but those may not be available outside those HIV specialist centres even today. So we know the pressure on mental health services in general means that there is still unmet need. And so even in an era of antiretroviral therapy, we are still seeing poor mental health and still seeing unmet need for its improvement.
And that was an issue that came up after yesterday as well, in that, as you say, we still have limited access to mental health support for patients with HIV, but actually it's probably better than for patients who have mono-infection with viral hepatitis, where often there isn't even funding for psychological support services. So sometimes people can access that through HIV services where it's available, but it's still a big issue in terms of accessing that.
Professor Anderson, I know you were involved in a study in 2004 which looked at stigma in a population in North London, and one of the findings from that report was that a lot of the participants were reporting that they had been discriminated against within the health service itself, and they reported discriminatory behaviour as a result of their HIV status from GPs, from dentists, and from hospital workers outside HIV. I just wondered if that is something that patients have reported to the panel, and what challenges and consequences arise for patients and for those trying to care for them.
So the study you're alluding to, we carried out, a group of us carried out a questionnaire-based study for people who were living with HIV, attending clinical services in North East London particularly, and it was asking a whole array of questions about what life was like and the challenges that people were facing. But the particular question I think that you're alluding to, we asked a particular question, have you experienced discrimination consequent upon your HIV infection? Now, the thing we have to say is that this was a questionnaire-based study, so people were ticking a box. We weren't interviewing people like Sian was describing yesterday. So it is a subjective response to a question with a tick box. Have you felt that experience? And a very high proportion of people said that they had. And digging into that, you're absolutely right. It was an array of healthcare workers, amongst others. I mean, it wasn't exclusively there. It was within a greater societal picture. I think the thing that comes from that was that the people who'd been living with HIV for the longest had the highest risk of experiencing discrimination, often because they had been through more episodes of care, or they had longer time living with HIV for that to have happened. The question was quite specifically asked about, do you feel that this was a result of your HIV infection? And people's answer to that was yes. I think there have been strides made. I mean, we did the study in 2004. We wrote it up in 2008. But as Ian's alluded to, we've got the Positive Voices survey, which the most recent iteration was 2015, 16. So, and still we're seeing, okay, the proportion has gone down slightly, but we're still seeing people who are afraid to access healthcare because of the response that they may have. And ours was the first quantitative study to actually demonstrate this happening. And again, it has led to a whole array of attempts to think, what do we do? How do we move this forward? Because it's unacceptable in every possible which way. And again, going back to Ian's point about long-term conditions, more people with HIV are meeting more healthcare practitioners in more settings. So it's absolutely crucial that we address this.
I think also just remembering back the difficulties that we had persuading parents that their children's best interests were served by their GPs knowing. There was a great deal of resistance to the idea of general practitioners being informed about the HIV diagnosis, and that was partly driven by experience that where, I don't know whether David can attest to this, but we would get reports back from the families saying that their notes and their children's notes would have a big red spot or something to identify them as HIV infected. It was vaguely covert in that it wasn't actually written HIV, but it was everybody in the practice knew, and they didn't want to experience that. They didn't want their children to experience that. And the other element was in the school system as well, that there were sometimes advantages in the school understanding why the child was missing a lot of school because of hospital appointments and inpatient care episodes. But then there was an issue about the transfer of that knowledge from primary education into secondary education without anybody thinking to ask the family and the child in particular whether they agreed with that. I mean, there was a really big issue for us.
Sorry, I think that's absolutely true, and I think in primary care there would have been a concern that people were stigmatised at one end of the spectrum. I think at the other end of the spectrum, people didn't want it recorded on their notes because it did have implications for life insurance and getting a mortgage and all sorts of things like that. In terms of school, a certain experience of kids being asked not to take part in sport because there was some risk of something, and just again the whole stigma that general practice, maybe a smaller community, and though of course confidentiality is at the heart of everything that we try to do, there is always just that concern that some information might become known. So absolutely, I think that's a valid point.
At the same time as Jane was doing the quantitative data, we were collecting qualitative data from people with haemophilia and HIV, and as I mentioned the other day, and then secondly, their families. I think what's just to add on to that I've recently done a same situation, a life history with healthcare workers, and I just on this subject, I talked to a number of community HIV specialists. Their job was to refer to GPs and services in the community outside of the hospitals that they had been treated so that they could go home. And many of those nurses who were trying to make those referrals came to huge resistance from many services who didn't want to take on board the care of a patient with HIV infection. And that, of course, also things like undertakers, you know, people who struggled with trying to get their partner being taken away who died, and the resistance of undertakers. So it was widespread discrimination across the board. And like we keep saying, there were some very specialist centres where people, even today, people walk into a clinic that I work in because it is a sexual health clinic, and they say, when I walk through this door, I feel safe. But out there, I never feel safe. And I think that's today. So. Yeah.
And Professor Anderson, you touched on this. The consequence of that to those that are infected and affected not only is psychological and emotional, but a reluctance to access healthcare services. So a direct impact on their physical health.
Absolutely, no question. And even today, I can think of a woman who said, "Oh, I've been called for a mammogram, but I just don't want to go because they're going to start asking about my HIV. I think I won't go."
Before we break for lunch, can I just pick up a few questions about co-infection? We covered some of it yesterday, co-infection with hepatitis. Covered some of it yesterday, and I don't want to go back over that. But that was primarily from the point of view of hepatitis. But from what I've understood, co-infection with hepatitis B or C, when one has HIV, doesn't alter the natural course of doesn't alter the HIV, the way the HIV develops. It's really, the alteration is all on the hepatitis.
The other way, in general, yes, that's correct.
What I would like to ask you is the difficulties of managing the two infections together. So whether it's a hepatitis B or hepatitis B and HIV or hepatitis C and HIV. Are there difficulties in taking medication for both infections at the same time?
So certainly that is true, and I think we touched on some of that yesterday. And it's slightly different issues depending on whether you're infected with HIV and hepatitis C or HIV and hepatitis B. But I think we talked at length yesterday about interferon and the challenges of taking interferon. And we know that for individuals infected with HIV, particularly those with advanced immunosuppression who needed hepatitis C treatment, the treatment was more difficult, it was more prolonged, and it was less likely to work. And so all of those factors combined alongside the additional toxicity that you might have taking those medications with medications for HIV were huge challenges which were a barrier to both starting care and having successful treatment for hepatitis C. And we know that without effective HIV treatment, that hepatitis C progresses more quickly and the incidence of serious liver disease is higher. And that has changed in recent years, but it was certainly the case for a very long time. And similarly for hepatitis B, we know progression was more aggressive, and until relatively recently, we didn't have specific treatments for hepatitis B that could be taken easily with HIV treatment. That's improved slightly with the advent of some medications which are active against both viruses. But we still have a few patients who require different sets of medications for their HIV and hepatitis B. So certainly additional challenges, and particularly around the additional toxicities of drugs that were being used.
But the choice for the patient is whether or not to take the medication for the hepatitis rather than whether or not to take the medication for the HIV, if I can put it that way.
Yes, and that's changed over time. And I think that balance of, in particular, so obviously these days we haven't really touched on this yet, but we would be recommending everybody with HIV to be on treatment, and that wasn't always the case. But by and large, by the late 80s, early 90s, most patients would be on some treatment which would be quite toxic. The decision to whether to take hepatitis C treatment would be a balance of how likely it was to be effective, balanced against the toxicity risks of taking it. And yeah, so that would have been an issue, particularly before the advent of highly active antiretroviral therapy.
And to reassure you, I am going to be asking you questions about treatment for HIV after lunch. Is there anything anyone wanted to add to that discussion?
Well, that brings us neatly, I think, to our lunch break, 2 o'clock. 2 o'clock, please.